Now, most of you know me. I'm Lou Pfeffer, a nearly 15-year prostate cancer survivor. On the 13th of this month, I celebrated my 80th birthday. I've had so much fun and excitement during this week that I believe it's the best week I ever had. I was diagnosed with prostate cancer in September '93. It was like the dark ages in prostate cancer. There were almost no books on prostate cancer, nor money for research. There was one great prostate cancer newsletter, PACT, published by Lloyd Ney in Grand Rapids, Michigan. He was my hero, and sometime we should have a special meeting and tell his story and honor him. When diagnosed with prostate cancer, I didn't even know I had a prostate. I was dumb, scared, feared. I feared I was going to die in a few weeks. Luckily, a friend told me to talk to Bill Dane, who with Murray Corwin co-founded this prostate forum of Fullerton. And even then, the meetings were held at this church. And I was helped so much that I asked to become a member of the board. Though I didn't know anything, I was willing to help in any way, to give back for all they did for me. And as of the first of this year, my dear friend Murray Corwin asked me to take over the leadership of this group, and I am very honored to be asked. These evening talks are recorded on videotape and made into DVDs so that they may be referred to later by our members and so that new members may have access to these talks, and also so that they may be distributed to other prostate cancer support groups. Before introducing tonight's speaker, I need to say that the Prostate Forum of Fullerton neither recommends nor endorses the views expressed by our presenters. Neither do we recommend nor endorse the position or opinions of individual attendees, including those of the individual directors of the Prostate Forum. And may I direct your attention to the disclaimers up here, which say we share information, but we do not give advice. These statements may seem obvious, but in today's litigious society, it's necessary to emphasize them at our meetings. And now I have the distinct pleasure of introducing our special speaker. Tonight is USC night. Notice I have on my USC jacket. And my grandson Robert and I are big Trojan fans. And our Prostate Forum has a close connection to USC. Our speaker tonight is Dr. Isla Skinner, who has an extensive CV and outstanding credentials. And here are a few highlights. She graduated from Stanford with 5 Beta Kappa honors, and then from USC Medical School with 5 Kappa Phi honors. She went on to intern, then resident at the LA County USC Medical Center. Dr. Skinner has written very many papers and participated in numerous research projects. She is an associate professor of clinical urology at USC. She is currently the chief of staff of Kenneth Norris Hospital, as well as the chief of staff of the USC University Hospital. We thank you, Dr. Skinner, for taking time from your very busy schedule to come and speak to us this evening on open radical prostatectomy. What is its role in 2008? Please give Dr. Skinner a warm welcome.
I actually first met Bill Dane and Murray Corwin back, I'm thinking 10 years ago. I've been involved with a group called Real Name Cook in Los Angeles that has been a organization that one of my patients has run that is giving information and also prostate cancer screening for African American men in Los Angeles, and we go to churches, and actually now my residents do all the work of seeing hundreds of patients at a time, and I get all the results, and we get their PSAs and tell them how they're doing. And it's really been an amazing program. Dr. Parrott, who's my patient, who built this from really the grass level, and we now see about 1,000 patients, 1,000 participants a year, so it's quite impressive. But at that time, this organization was one of the few support groups that existed, and it really was sort of the father of that. And so when I got invited to come here, I immediately realized the connection, and I don't always accept these invitations, but I was happy to come. What they asked me to come speak about is open radical prostatectomy, and I feel a little bit like the dinosaur, because everybody's talking about the robot, and that's obviously the sexy thing to talk about, but I wanted to focus on what's real and what's hype, and talk about, what is important when we're talking about prostate cancer surgery, and what is the role of the robot, and what can you expect from that, and what's the role for good old-fashioned open surgery. I'm sure that many of you in the room have had open surgery, so I want to make you feel like you weren't left behind. I also I really wanted to have a picture of my very good friend and colleague, John Stein. I think some of you knew John, and others have heard of him. He passed away at 45 2 weeks ago. I have a hard time not getting choked up about this, because he was really a member of my family. He and I trained together, and he was a few years behind me in our program, and has been a colleague, and actually had been appointed to be the new chair of the department, and contracted a really mysterious, horrible infection and died in about 12 hours from when he got sick. So we still don't exactly know what happened, but we're still kind of reeling. And I just wanted to mention that because I think it has a big effect on all of us. So where are we with prostate cancer? And some of this, you all know, when I talk to lay groups, you guys, I know, many of you know a lot about prostate cancer, and I don't want to underestimate that, but I also don't want to show you 8,000 statistics and a lot of graphs and so on. I'm going to try to keep this pretty simple. I'd be happy to go into more depth during the discussion if this is too superficial, but I think there are some really important controversies in prostate cancer treatment right now, especially talking about localized cancer, one of which you're well aware of is who should be treated. We know that we are over-treating a lot of patients, but we can't identify who needs to be treated. How do we determine which treatment is best? Currently, the state of information is really that it's whoever yells the loudest or is the most convincing is kind of the best we can do. When should we use combination therapies? Those are all really important controversies. The least important thing in this whole business is whether you have surgery with a robot or you have surgery open. So I want to just put this in context, because this is where there is a lot of focus right now, and it really is not the most important thing. And I just want to talk some about what our goals are when we go to do a radical prostatectomy. Hopefully we've identified the patient early enough and the cancer is only inside the prostate. Our goal is to remove the whole prostate, seminal vesicles and pelvic lymph nodes. That's our standard radical prostatectomy. We want to avoid major complications, death from the surgery or some other major complication in the hospital. We like to avoid transfusions. We want to avoid positive surgical margins, because we know that can relate to late recurrences. And we want to preserve continence and potency. So that's kind of how we approach the surgery. What guides our treatment choice? Because every single patient that comes to see me with newly diagnosed prostate cancer gets a very long discussion about the options. And these are the things that I take into consideration when I'm having that discussion. There's a few things related to that patient's cancer. Clinical stage, Gleason grade, PSA. Those things are actually important, but the things on the right side are perhaps more important sometimes, and that is things like patient's age, his general health, family history, symptoms, and is wishes, which is probably more important than anything else. So all those things go into the decision. And I just wanted to give you a couple of examples of where, again, I'm trying to set the stage for the fact that I think that exactly how the surgery is done technically is not all that important. This is the first patient, a very typical patient that we see, 72-year-old retired executive, has some hypertension, a little elevated cholesterol, but basically is healthy, has no symptoms, gets his PSA done once, maybe even twice a year, maybe even every month if he's really crazed about it. And he's watched it increase from 1.5 to 3.2. And we now know that even though that's well within the normal range for a 70-year-old, if you see it go up that fast, it at least gets our attention. So he has a normal exam, he gets a biopsy, single core of Gleason 5%, Gleason 6 prostate cancer. This is a big chunk of our patients today look like this. So the question for this patient is, does he need treatment at all? Is he likely to die of something else before the cancer is going to get him? And which treatment has the least side effects? And the reason that's so important is that we know that his chance of dying of this prostate cancer is low. This was Albertson's data showing that Gleason 6, less than a third of the patients are going to die of their prostate cancer out to 15 years. And at 72, 15 years is a nice long chunk of time, although he might be destined to live longer than that. So because this is probably not a life-threatening cancer, we really focus in on the side effects of the treatment. On the other hand, this is a patient who came to me about a year ago, 44-year-old, started having urinary symptoms. His doctor naturally took a long time to figure out that the problem was prostate cancer. When he finally did a PSA on him, it was 200. So this patient was in big trouble right from the beginning. Bilateral, hard prostate on exam. When we did his biopsy, 7 out of 12 cores had Gleason 9 prostate cancer. Fortunately, he didn't have any obvious metastatic disease, so we did a whole workup on him and couldn't find anything outside the prostate. But we know that this patient is not going to be cured by any one treatment. It doesn't matter if you have 6 robots in that room. This guy's not going to be cured by surgery alone. It doesn't matter if you have the fanciest radiation therapy equipment or the bazillion seeds to put in his prostate. He's probably not going to be cured because this is a very aggressive, highly metastatic prostate cancer. So this patient needs the best resection because he's 44. You don't want him to have a local recurrence, but he really needs combined therapy. And this patient actually had been advised by a community urologist, oh, we'll just take out your prostate and you'll be fine. And I said, I didn't think that was adequate. And so he's been on hormone therapy, he's got randomized on a clinical trial, he got chemotherapy after surgery. So we're throwing everything at this guy because we want him around for a long time, obviously. And we also want to have few side effects for him, but that's way down on the importance level for a patient at that age with that kind of disease. So just putting it all in context. So what matters? Obviously, your convalescence from surgery matters, just the general recovery from the operation. Continence and potency are probably the things that matter the most to most patients. And of course, cancer control. In fact, most patients coming in the door, this is the thing that they're the most worried about. Later on, they start worrying more about continence and potency after they figure that they're actually probably cured. And Peter Scardino at Memorial Sloan Kettering coined the word the trifecta. If you're 5 years out from surgery, you have a 0 PSA, you're completely continent, and you're completely potent, you won. That's what we're actually aiming for. And many people have taken his advice and thought this is really what we should consider a success. It's not always reachable, and I don't promise that I'm going to reach that for every patient, but that's what our goal is. And down at the bottom is cost, which is not so much an issue for us individually or even us, in our houses or whatever, but it's a big issue for society. And it's a big issue for some patients where cost is a big driving factor. So what are the parts of convalescence of that early hospital course that matter? Well, time in the operating room matters. That matters a lot for cost, but length of anesthesia does have an impact on your body, and the longer the anesthesia, the longer recovery you're going to have. The length of hospital stay, probably a little less important. It seems very important at the time. It doesn't really make a huge difference, and it's determined by a lot of things, and I'll talk about that in a second. Estimated blood loss is important. If you're very anemic after your surgery, you don't feel good, it takes you longer to get your energy back. If you don't lose as much blood, you do better. If you have to have transfusions, we know that that's not necessarily a good thing. If it's your own blood, there's not much risk to that, but if it's somebody else's blood, there probably is a small risk. We can measure things like pain management, pain medicine requirements. Obviously, things like major complications. If somebody has a pulmonary embolism after surgery, that's a potentially fatal complication. Fortunately, it doesn't happen very often. In our series and pretty much every other open prostatectomy series, about 1 in 1,000 patients has died of a complication of surgery, which is still higher than we would like, but it's much lower than most of the other surgeries that we do for cancer. And recovery time, and honestly, recovery time, how long it takes you to really be back to 100%, to feel like you've never had surgery, is something that's not well quantified at all, in any series anywhere. And that's, I don't know if any of you who have had surgery have ever had anybody ask you that question, but we don't ask very often, and I think it's something that we need to focus on. So what are the predictors of outcome? I apologize, this is a little bit small, but the predictors, there's several things that can predict outcome that don't necessarily have anything to do with how you do the surgery or who does the surgery. So one is the patient's characteristics. How old is he going into surgery? What's his potency before surgery? That's a very strong predictor for potency after surgery. How obese is he? We have a much harder time with our patients who are very obese. What other medical problems does he have that might have an impact, like diabetes, on healing or recovery? How many previous surgeries? One of the ones that's the most difficult for us, both open and laparoscopic surgeons, is if someone's had previous laparoscopic bilateral hernia repairs, because what those surgeons love to do is take a nice piece of mesh, lay it inside the pelvis all the way across from one groin to the other, and that's right where we want to go. So it ends up, you get this really intense scar tissue in there. Makes it seems like a minor surgery when you're having it done, has a big impact on this operation. Tumor characteristics impact outcome, stage and grade. So they clearly impact things like positive margins and recurrence rates, but there's some evidence that they impact other things like continence and potency. And so that's an important factor. Very clear that the training, the skill, and the experience of the surgeon matter. And Dr. Scardino and James Eastham, who Dr. Eastham actually trained with us at Memorial Sloan Kettering, have really been forerunners in looking at individual differences between surgeons. Surgeons don't like to talk about this very much, and honestly, even in our group, we're just starting to look at this because it's very, you can just imagine if you're getting graded essentially on your surgical skill. Nobody likes doing that. But what James Eastham did is he looked at Memorial Sloan Kettering. They have a lot of surgeons there. Peter Scardino and James Eastham do hundreds of prostatectomies a year, but there's lots of other surgeons who do a lot. And they looked at a lot of aspects of this, and even surgeons with similar experience had different outcomes. But clearly experience outweighs everything else. And I'll show you a little bit of data about that in a minute. Patient expectations also determine outcome. And the easiest example of this is looking at length of stay in the hospital. When I started in practice, when we did radical prostatectomies, patients all stayed 5 days. And we just told them when they came in, you're going to stay 5 days. We had a plan for them every day. For some reason, we thought they needed to be there the whole time. And we were horrified when it was really the insurance companies who made us kick them out in 2 days. So we thought that was going to be a disaster. And so we started sort of begrudgingly telling the patients that we really wanted them to stay longer, but their insurance company was making them go home in 2 days. And those patients didn't feel good in 2 days. They weren't ready to go home. We often had to keep them longer. But then, as we realized that that wasn't really, in fact, the patients did fine when they went home in 2 days, we started telling the patients, you're going to go home in 2 days. And now, almost all my patients feel ready to go home in 2 days, and they do fine. What Jay Smith, I'm going to talk about in a minute, basically started off when he started doing robotic prostatectomies. He started giving patients the exact same instructions before surgery, whether they had an open surgery or a robotic surgery, and sure enough, they left the same day. Their expectations predicted how they felt and when they went home. So a lot of this is a matter of what you expect and what the sort of the protocol is at that hospital. So patient expectations matter, and it matters in other things to some extent, like continence. If you start questioning people about continence, what they expect and how you ask the question really can influence the results. And that's why it's so difficult to look at different series and say, well, this guy's obviously better because he has lower incontinence rates, when in fact they may not have asked the patients the same question, or they may not have asked it in the same way. So it's really patient expectations and doctor expectations also influence all this stuff. Pathologist technique have a big impact on the whole question about positive margins. And what that means is when we take out the prostatectomy, they look at all the edges. Is the cancer out to the edge where we cut? We're very limited. I'm sure you guys know this already, but we're limited in how much tissue we can take out. So if the cancer is at the margin, we know that those patients have a higher recurrence rate. But how the pathologist handles the tissue really influences your positive margin rate. And how you define, is it one gland with cancer in it at the margin, is that a positive margin, or does it have to be 5 millimeters, or does it have to be some other arbitrary limit? So that's again why it's hard to compare different series. So the only way to validly compare techniques, because of all these things, is if the same surgeon flips a coin and half of his patients get one technique and half get the other. And if you follow anything about the prostate cancer literature, that never happens. There's no series anywhere that's a randomized comparison of two different techniques in prostate cancer surgery. And it doesn't matter what you're talking about, whether you're talking about nerve-sparing techniques or how I handle the apex that determines continence, or whether I use a robot or a lap or open. None of those things have ever been compared in a randomized fashion. And, part of the reason is that doctors always are sure we know the answers. So we're sure that whatever we're doing now is better than what we used to do. But we also don't think that patients would sign up for a randomized trial like that. Now, in my career, women signed up for radical mastectomy versus lumpectomy, and that trial got done in a very expeditious fashion, but it's never been done for prostate cancer. So, all the reported series, and if you go on, I'm going to talk about this again later, but if you go on the Da Vinci website and look at their quotes about what the advantage of the robot is, they will give you lots of data, lots of references of studies that have proven that the Da Vinci is better. And every single one of those is either a comparison of one guy using the Da Vinci versus a bunch of guys using the regular prostatectomy, or guy in one institution using the Da Vinci comparing his results to some other institution or some other reported series. Or the same surgeon, and Dr. Allering, your local guy here, has published this kind of results. I used to do open, now I do robot, and my results are better. Well, if I looked at my own results 5 years ago and my results now, they're better. Doing the same surgery, you get better at it. So consecutive series are not good. And contemporary series, the same surgeon, and this is what Jay Smith has done at Vanderbilt, is he started doing robotic prostatectomy. He didn't randomly assign the patients, and that's always a potential flaw, but he did basically let the patient choose. And so they're contemporary, meaning he might do 2 robots and 2 open in the same week. He's not necessarily comparing his recent experience to his old experience, and I'll show you some of his results. Well, here it is, right here is main thing. So, what's the learning curve? So Jay Smith, who's one of my favorite people at Vanderbilt, began doing these surgeries, and he had already performed over 1,000 retropubic prostatectomies when he started. His conclusion, he's a phenomenal surgeon. So his conclusion was that it took him about 150 cases to get as good as he was open. And it took him almost 250 until he was comfortable, meaning his heart wasn't racing at some point during the operation. Other people have, and Dr. Allering is one, have felt that you can actually shorten this learning curve, but most robotic surgeons that I will have heard speak think that it's somewhere around 50 cases. So keep that in mind. So what Dr. Scardino and the folks at Memorial did is they looked at the learning curve for open prostatectomy. And nobody really had ever really looked at that before. And he and several others looked at their series over the years and how much better they got. And what they found was that whether they used positive margins as a endpoint, so you figure, how am I going to decide if I'm getting better? Well, I can look at, do I have less recurrences? I can look at positive margins, or I can look at continence or potency. And what he found was, no matter what the outcome was, that it continued to improve out to about 250 cases. So there's a long learning curve for open prostatectomy also. The difference in today is that most doctors, urologists in training get through a lot of that learning curve while they're in their training program. So that by the time they're out in practice, they're still getting better, but they're somewhere up here at the top of the curve. And eventually that'll be true for the robot as well, but it's not true today. One of the points that Dr. Scardino made, which is really kind of distressing, is that 90% of urologists today who do radical prostatectomy do 10 or fewer a year. And another chunk do maybe 20 or fewer a year. So we know that patients do better if surgeons do whatever the operation is often, and this is a bit of a problem. So this was another publication from Jay Smith looking at the world's literature on robotic prostatectomy. This was his own series. It was not the world's literature. This was his own series. So in the left-hand bar, at 3 months, 6 months, and 12 months, is continence. So patient was either completely dry or used one pad. And he looked at his first 100 cases, his second 600 cases, and his own open prostatectomy series is in the far right. And at the beginning, the second 100 cases do a little better in the robot. In other words, the early continence got a little bit better from his first 100 series to the second. But by 6 months and 12 months, all 3 series look the same. So he did not see, even after he had done 700 robotic prostatectomies, his outcomes were exactly the same in terms of continence. Similar results in terms of potency, similar results in terms of positive margins. So what I tell patients, and this if you critically review the literature and look at the results with robotic prostatectomy, what I tell patients is, if I do your surgery, usually you stay in the hospital 2 nights. There's actually no reason in the world that most patients couldn't go home in 1, but our habit is to keep them for 2. Most robotic surgeons keep their patients 1 night. Transfusion rates are a little bit lower with robotic prostatectomy because of the air that's pushed into the abdomen that keeps the pressure on the vessels. Readmissions are about the same. In other words, complications after you go home that would make you come back to the hospital are about the same. If playing golf is your end-all, you may be able to play golf a little sooner after a robotic prostatectomy than you would after an open prostatectomy. Continence is the same, potency is the same. And that I think is supported by the literature and by the reports. So clearly there is less blood loss with robotic prostatectomy. I think experienced open prostatectomy surgeons have a very low blood loss and a very low transfusion rate, but it is lower with robotic. There is less postoperative pain. Patients use a little bit less narcotics. There's a little more rapid return to exercise. But there's no difference in continence or potency. There's no difference, especially after 1 to 2 months, in terms of the recovery. And this is what I was saying in terms of getting back to your normal activities. By a couple of months, patients look the same. And there's no evidence that there's any difference in terms of cancer control. So there are a few complications that seem to be worse with robotic prostatectomy, and this is partly experience-based. So people, when they first start using the robot, you get no feedback from it. So you have no feel. You're sitting over in the console running the robot, and your assistant is helping at the bedside. But when you move the arm of the robot, if it's poking a hole in something, you don't have any way of knowing unless you see it happen. And early on, rectal injuries were actually significantly more common. In the reported series, there are many, many other small series that just don't even talk about it. But clearly rectal injuries are something they can occur through an open prostatectomy, but they're generally recognized and repaired. If you don't recognize a rectal injury, those patients end up with a fistula and need another surgery and have some potential real disaster. So that clearly is a little bit more risk. There's also something called an ileus. So that means that when you get general anesthesia, often you get bloated and your bowels don't work very well for a couple of days. That can be very prolonged in the case of a robotic prostatectomy if they go in the peritoneal cavity. So the standard retropubic prostatectomy that we do open, you don't open the abdominal cavity at all. You just push it out of the way. So that if somebody leaks urine, for example, it's confined to this area of fat and it just gets reabsorbed. If you leak urine into your belly, it makes your intestines not work for a few days. So ileus, due to urine leak, can be much more of a problem with a robotic prostatectomy. So every once in a while, somebody has this surgery and ends up in the hospital longer or getting readmitted. And this is something that we've seen as a referral situation, and I have no idea how common it is. But we've had a series of about 8 patients who had robotic prostatectomies done outside in the community somewhere and were surprised that their PSA didn't really go down very much. And it turns out that only a little bit of the prostate had been removed. Most of the prostate was still there. So that's something that anybody who's an experienced open prostatectomy surgeon, you can't do that because you're sitting there looking at it. But I think the one thing about laparoscopy and robot is that it's easy to get confused. And if you're not experienced at it, I think that this is something that is a potential risk. Now, that, I have no idea how common it is. I think it must be rare, but we have seen several of them. So what's driven the adoption? I'm sitting here telling you it's no big deal, there's no improvement, it's not, why are we doing this? Well, urologists love toys. If you ask people why they go into urology, and I tell my medical students this all the time, we have great toys. And the very first toys that urologists had were cystoscopes that had a candle at the back. And you know, you could look in someone's bladder and take out a bladder stone back in, I don't know when, 1800s, way before anesthesia, way before anything else. So toys have been a central part of urology from the beginning. So this just falls right into our hands. This is really a fun toy to play with. You get to sit down during the surgery. And many urologists have bad backs from bending over and operating for many years. They love to be able to sit down and do surgery. So that's good. But really what's driven the adoption of this technique has been marketing by the company that makes this robot. And there is no competition. They bought the competition, so there's one robot. And they have a very aggressive marketing technique. It's about 1.8 million when you add up the cost of the maintenance contracts and so on. So it's a major investment by the hospital. Dr. Rojas Cruz at the AUA presented a really interesting study. They were looking at misinformation on the robotic prostatectomy websites. And most hospitals that have bought a robot will put it on their website and make a big deal about it, obviously, because they want it used. So they looked at 116 hospital websites that had robots. 75 of them described their robotic prostatectomy, half for university and half for community. 42% contained text that was exactly copied from Intuitive's website. So they took the company's website, they just said, this is a better operation because Intuitive said so. Another 40% had links to their website. And so the information that's out there is being largely driven by the company that's selling the robot. And the Intuitive will say that it's the patients that are driving it, but honestly, I think it's the company that's driving it. In Canada, they're just getting their first robot because they just said, why do we need one of those? Didn't make any sense to them. So why haven't I adopted a robot? You think I'm probably young enough, I could learn something new. It does look like fun. I've played with the robot. I've done stuff in the lab with it. The learning curve is at least 50 cases and maybe more. So the question is, who wants to be my first 50 cases? Nobody would sign up for that. And I can't look a patient in the eye and tell him what results I can get with open radical prostatectomy and tell them that I think he should accept worse results while I get trained at this new technique. So, and then after those 50 who I've spent on learning this, are the rest of my patients any better off? I don't think so, really. So that's why I personally haven't adopted it. So nationally, multiply that by all the urologists in the country. 1,000 urologists at least out there doing radical prostatectomies, 50 cases each, 50,000 patients on the learning curve of radical prostatectomy, robotic prostatectomy. So what is the future? So the other reason to adopt this technology is that it will improve. And if you look at the Da Vinci robot, it looks like the first IBM computer, which probably a lot of you remember. It's as big as a room. This thing is huge. It's very ungainly. You look at it and you think, they gotta be able to make that smaller. It's a big piece of equipment. It is very cool, but it's about the third generation right now, so it's got a long way to go. It will get better, smaller, and cheaper, especially if we get some competition. So any of you who are good inventors, please go out and invent a competing robot. Eventually, I think robot-based technology will help us get better outcome, because you can potentially build in all sorts of sensors into the robot. So you could, because it's got such fine ability to get down to detail, you could imagine a way to build in something that would allow you to see the nerves very clearly, or test continence during surgery and say, okay, I shouldn't cut that because that's going to affect something or whatever. So I do think that the technology is the future. I just don't think we're quite there yet. As young surgeons learn robotic techniques in their training, then that learning curve will go away. It will still be there, but it'll just be part of training. And unfortunately, even places like UC Irvine, where they've been leaders in both robotic and regular laparoscopic techniques, a lot of it is being done only in fellowship training, so the residents are just starting to get brought into this kind of training. The difficult part of it is, as the cases become robotic, they're not getting exposed to the open surgery, so as these surgeons become better at robots, they're going to become worse at open. So eventually, probably the whole thing will change. But that's the future, I think. So today, I think all the outcomes that we can measure, other than the ones I've mentioned, are going to be essentially dependent on your surgeon's skill and experience and the other factors that I mentioned, your expectations, your cancer situation, your health, rather than whether a robot is used to do the operation. So I'm going to stop there after getting on my soapbox for a while, and I'd be happy to take any questions.
Okay, for the questions, if I could ask anyone with questions to come up here to the front.
Thank you, Dr. Skinner, for coming all the way from USC this evening through traffic. We appreciate the talk. One of the real problems in what I assume is a very technically difficult operation is to select a surgeon that is most skillful, and presumably outcome would be the way a patient would do that. But how would you tell us the pitfalls of that? And if also, it seems to me that the surgeons connected with universities are more likely to have the staff to do outcomes rather than
Right. That's exactly right. It is a big problem because the hospital organizations, things like health grades and so on, would love to be able to grade doctors on a whole lot of different things. And as I said, this is a very politically difficult thing for doctors to deal with because we all like to think we're the best at what we do, for sure. And you're right, what often urologists in practice will quote to a patient is Pat Walsh's results at Johns Hopkins, because that's what was published. So I've known many patients who said, well, my doctor said that he has 70% potency. And it's like, well, how does he know? Because nobody has it. We have about, Dr. Skinner, my boss, who I'm not related to, by the way, I think our budget for our databases is about $400,000 a year for the people who keep track of all of our prostatectomy patients and all of our bladder cancer patients. So nobody in private practice is going to do that. So you're absolutely right. There's no way to get that kind of outcome data. When I was having kids, I had no idea if my OB was any good. Honestly, I just didn't. I don't know how you know. You know whether you like them. You know whether they make sense. You know whether they match your personality. That's about all you can do. I think the best source, what I tell my friends to do, is to talk to, if they know any anesthesiologists, to talk to them. And if they know any OR nurses, to talk to them. They're the people who actually see doctors operate. They don't necessarily know about their outcomes, but they know kind of what they're like in the operating room. But it's very difficult. It is completely fair to ask a surgeon, how many of these cases do you do a year? Now, they might lie to you, and probably all of us tend to inflate it a little bit, but that's a completely fair question. And you can ask them, what are your outcomes? But they're probably not going to be able to tell you that exactly.
Right. Dr. Skinner, I have a question from a friend of mine who couldn't be here tonight. And it is, if radical prostatectomy is the gold standard for local prostate cancer, why is it not used for advanced prostate cancer?
Oh, that's a good question.
And a little bit more.
Yeah.
Has there been a clinical trial that proves that prostatectomy is not indicated for advanced prostate cancer patients?
That's one of those, like that 44-year-old patient that I showed you. We know that for localized prostate cancer, radical prostatectomy has pretty good outcomes. I don't know if you could say it's a gold standard. Lots of urologists will say that. Lots of radiation therapists would argue about that. I don't think it's proven one way or the other, but we'll call it the gold standard for now. For many years, Pat Walsh would go around and say, if you think that cancer is outside the prostate, you have no business taking out that prostate. Or, if the patient is 1 day over 70, you shouldn't do that operation. And I've never believed either one of those, actually. I mean, I think that if somebody has locally advanced prostate cancer, there is a role for prostatectomy. And your goal is a little different. Your goal in that situation is local control. So if somebody has, like my 44-year-old patient, PSA of 200, big rock hard prostate, Gleason 9, I know 90% chance he's got disease somewhere else in his body. So my goal of taking out that prostate is, because if I don't, he's going to be miserable before he dies. So that cancer is going to cause him so much misery. Radiation therapy can't treat that. Once it's started to grow, now hormones aren't working, he's going to be, not able to urinate, he's going to block off his kidneys, and there is pretty good data that says that you can get better local control with radical prostatectomy in advanced disease than with those other techniques. Now, having said that, there's a limit. So technically it's difficult to do because as the cancer gets outside the prostate, it can invade close to the rectum, it can invade into the bladder up where the kidneys come in. So it technically can be very difficult. Much higher risk of rectal injuries, even in the open surgery, much higher blood loss, much higher risk of incontinence. And you really can't do nerve sparing. So, some patients who have locally advanced disease, and I had a patient not that long, well actually, it's been a while now, but also clinical locally advanced disease, and I told him I thought we needed to do combined therapy. And I started him on hormone therapy, and he said, well, why do I want to have surgery? I feel fine. Why, I don't want to do that. So he didn't, and he just stayed on hormone therapy for about 8 years, and it wasn't until really close to the end that the prostate actually caused him trouble. So we don't know the right answer to that. If somebody has bone metastases already, then the likelihood, unless he's really symptomatic from his prostate, the likelihood that that's going to be a problem for him is not that high. So, and the benefit is low in that situation. So I think somebody with advanced disease, needs to go to a cancer center, honestly, in my opinion, because I think then they at least will be willing to kind of think a little bit outside the box. And especially if they're young and healthy, and we can try throwing a lot of different things at it. But in a lot of other cancers, debulking is actually been proven to be beneficial. It has not yet in prostate cancer.
This applies to either type of surgery. Do we know what causes the accumulation of scar tissue and that can occur in some of these surgeries and go on for 2-3 years after the surgery, continually sealing off the bladder?
So you're talking about a bladder neck contracture or a stricture where we reconnect the bladder to the urethra, and that can happen with either type of surgery. The short answer is no, we don't know why that happens. There is a bit of a technical factor. In other words, there are differences in the rate of that happening between different surgeons. Again, it's not something you're going to ever be able to find out, but it's something that we look at our own, part of the idea, going back to this whole thing about grading your surgeon, you folks want to know who's the best surgeon so you can go to that person. But we need to know so that we can train all of us to be as good as the best guys. So if I knew who in my group was the absolute best, I could spend time with that person and actually learn from them. Or if I knew that my bladder neck contraction rate was worse than everybody else's, I need to figure out why that is. But there's no surgeon who doesn't have an occasional patient who gets that. So it's not completely surgeon dependent. It's much more likely with someone who's had radiation as well. So if you add radiation after surgery, or if you have had radiation before surgery, that tissue, radiated tissue, really likes to do that. But you know, if you look at how people's scars heal, that probably gives you a little bit of a clue. So you can make the exact same incision in 20 different people, and some will end up with a very fine line that just looks beautiful, you can hardly see it, and some will end up with a big, thick scar. The worst of that is called keloid, but even short of that, you know, people lay down different amounts of collagen, different amounts of scar tissue. So there are undoubtedly patient factors that can predict it as well. We just don't know what they are. But it is one of the most difficult things to treat.
The other question is, how do you determine positive margins during a surgery, or is that done afterward?
It almost always has to be done afterwards. There have been folks that have tried doing frozen sections, and the difficulty with frozen sections is, first of all, they take a long time, but secondly, because if you take out a prostate, when I do a radical prostatectomy and hand the specimen to the pathologist, they can chop it up, and they're always bringing it in and say, oh, see right here, it's a little yellow. You can't see prostate cancer, honestly. If it happens to grow in a nice big fat lump, you can see it. But most prostate cancers don't grow like that. Most of them are sort of peppered throughout the prostate, and they're not visible to the naked eye. So if we ask the pathologist to do a frozen section, we're asking them to essentially do the impossible. Guess where the cancer is, and do a margin there and tell me whether it's positive or negative. So it hasn't, what they did, UCLA did a series like this where they did frozen sections where the nerves were to try to see whether they could choose who should have nerve-sparing surgery and who shouldn't. And they decided at the end that it didn't really help. So we generally, it's something we find out later. And there's gradations in positive margins. There's little positive margins that may not really matter, and there's extensive positive margins where we would recommend radiation, for example, to try to avoid recurrence in that patient.
I guess the positive margin is also determined by the skills of the pathologist in interpreting the data.
Yes. It's particularly problematic at what we call the apex. So when we come across the prostate, the base is where it connects to the bladder, and the apex is where it connects to the urethra. And what happens at that apex is you have this little sort of onion skin over the prostate that's the capsule. It's not a capsule like, you know, a nice, not like this plastic. I mean, it's just this little filmy stuff over the prostate. And at the apex, there's very little capsule. So you already don't have much of a covering there. When you cut across the urethra to separate the prostate from the urethra has muscle in it, so it contracts. So it sort of pulls that part in, and then what the pathologist is calling the apex might actually not really be the margin. So it's very tricky, and that's why some series have said that apical margins at that apex may not be as dangerous as other margins. Other series say yes, they are, and it probably just depends on the pathologist.
My question is in regards to the outcome as far as potency, continence, and the negative surgical scar. It's commonly mentioned in the literature, and also you reiterated this evening, 5 years, whether the surgery, whether robotic or open, whether one has survived and cure or not. Now, why is it 5 years? What's the rationale?
That's I think one of the most confusing things to patients, and I always try to clarify this, because when we talk about 5-year survival, we're not saying we only expect you to live 5 years. We say that because if you've gone 5 years with some kinds of cancer and the cancer hasn't come back, then it's not going to come back. Now that's not really true for prostate cancer. And you all probably know patients who have had recurrence 8 years, 10 years, 15 years later. So breast cancer is the same way. But other cancers like bladder cancer, if we take out the bladder and that cancer hasn't come back in 3 or 4 years, it's not coming back. They're done. They're cured, basically. So we don't really talk so much about cure for prostate because it's got this long natural history. But certainly in terms of other outcomes like continence and potency, by about 2 years, you're probably as good as you're going to get in that regard. But that's why the 5 years is arbitrary. Really.
Yes, that's kind of the traditional statement.
Right.
It's 5 years.
Right. And part of the thing with the robotics is they don't have 5 years.
But to hear a professional talk so candidly about her profession and those around it, because we value that a great deal. Matter of fact, one of my questions has to do with this recurring theme of how do you find the expert?
Right.
I have run across online, I'm sure others have as well, services which purport to offer you the best doctor for this purpose and that purpose, and there are books published and there are government published. Would you have a comment on the veracity of any of that?
I have no idea how they come up with that. Often they're using other doctors, asking other doctors who they would go to, and of course, I should probably be careful what I say, but my experience with doctors in the community is they typically refer to the doctors in their same building most often, and that may or may not be the best doctor. So I think there's very little credence to that. The government is getting involved in all this in a big way, and we're all a little terrified about it. But for example, in primary care, they've shown that if your diabetics walk around with a hemoglobin A1C, if any of you had diabetes, you know what that means. It's a way to measure your long-term diabetes control. So if your hemoglobin A1Cs are above a certain limit, you're not taking good care of your patients. And it might be that they're not teaching them, or it might be that you're not treating them right, or whatever. But that's been a grade that they can put on.
But patients don't do what they're told.
Well, no, I know, but they figure that's the primary care's job to, get somebody out there to make the patients do what they're told. So anyway, whatever, right or wrong, that's a grade that's being applied to primary care doctors in many HMOs, and pretty soon it's going to be applied everywhere. If you get admitted to a hospital today and you have pneumonia, if you don't get those antibiotics within 2 hours, that's considered a failing grade. And every hospital is getting graded on that, and it gets on the web. So this is going to be more and more. Eventually, urologists will get graded on things that matter more than whether you were part of the best doctors or whatever. So I always am suspicious when I get elected to one of those things, because it's like, how do they know? It's like, so I don't know. It's very hard. I totally appreciate how difficult it is. And I think, you'd like to think academic medical centers are better and likely to be better. I don't think that's probably always true, but SC, of course, is better.
In a different vein,
Yes.
you're still doing surgery. We have had other wonderful people such as yourself that come through, and we have a few ex-surgeons, I call them. They're doing Cs.
Right.
When I asked the question why, well, it's obvious the length of time, the freedom from biological recurrence is typically much better for Cs, for the appropriate patient, than it is for surgery.
Well, that's absolutely not proven at all. In fact, the best series comparing different outcomes with... So again, here's another example. If you really wanted to know what treatment was best for patient X with localized prostate cancer, you would do a randomized trial. You would recruit 10,000 patients, you would flip a coin, half of them would get surgery, half of them would get radiation with external beam, half would get seeds, or up to 3 halves already. A few more would get watched. So that's never been done. The Swedes, bless them, did a study comparing watchful waiting to surgery and actually showed in a randomized trial that surgical patients had better survival. Now, whether it was worth it or not, that's a judgment call. But there is honestly no data to say that the outcome from a cancer standpoint with seeds is better. There is a little bit of data that says for patients with worse cancer, seeds are probably worse than external beam and worse than surgery. But for the best patients, the guy with the Gleason 6 and 1 core, honestly, anything you throw at that patient, he's going to do fine. So now I do think that seeds done by the skilled person have a very low complication rate in terms of potency. They probably have a little better potency preservation than either external beam or surgery. But the trade-off is they have worse urinary symptoms. And that's been shown. There now are lots and lots of quality of life studies that really can tell you that. Now, if you start saying, okay, now you have a patient with Gleason 7, multiple cores, PSA is 12, most radiation therapists are not going to use seeds in that patient. They will use seeds plus external beam, maybe plus hormones. Now you're talking about some pretty significant quality of life issues. So I think people choose the treatment that they think is best in their hands. And that's why, you don't want to come to me and say, I want you to do my robotic prostate. You don't want that, because it would be my first one. That would be bad. You don't want, somebody else, you don't want Tom Allering to put seeds in you because he's never done it. So if you're, the best you can do is do what you do, which is read a lot, talk to people like you who've been around for a long time, and then go find some people to talk to who do the various treatments and see who makes the most sense.
Thank you.
Doctor, thank you for coming this evening.
You're welcome.
Very interesting. I'd like to ask a question, if you can put it in very general context. We have a patient that has appropriate other options other than surgery. Say they're equal, and he
Sure.
makes a choice. He tends to look at, and I would personally look at surgery as in and of itself a risk factor. And you mentioned
Absolutely.
time under anesthesia. Could you amplify that a bit? Is it the time under? If so,
Well,
when do we get concerned about being
Right.
under? How many, is that a half hour or 5
no,
hours?
it's, honestly, for radical prostatectomy, because we have other options. So if a patient comes to me who's had a heart attack and has a stress test that still shows that he's not getting enough blood to his heart, or he's markedly overweight and he's huffing and puffing just walking into my office, I'm never going to tell that patient to have a prostatectomy for his cancer, because we have honestly equally good options. Radiation is a very good option and probably has the same cure rate. Slightly different complications, but not worse, not necessarily better. So if there's anything in a patient's history that makes them high risk for surgery, we go to one of the other options. I honestly, I have a patient right now who he desperately wants surgery. His cardiologist says, you're crazy. You can't, you shouldn't have surgery. And I'm like, I'm not going to do it. I just don't think to put somebody in a life-threatening situation for something where there's equally good other alternatives. Now, people do die after radiation therapy because of complications or from, I had another patient, as an example, who was actually a family friend who opted for seed implants, and down the road ended up with a giant hole between his rectum and his prostate, and ended up having to have a huge operation. It would have been much better off in retrospect having a little operation. So there's no treatment of prostate cancer that's without risk except watchful waiting. So in that sense, hopefully your doctor, especially your primary doctor, but the surgeon also should be able to look at you and your medical history and say, you know, I think you're going to do fine with anesthesia, or, gee, we got to really worry about that. It's not up to you to make that decision because you don't know, you know, but, so the length of time matters, not necessarily in a big way. In other words, if I do 2-hour surgeries and compare them to 3-hour surgeries, there's not a higher mortality from 3-hour surgeries. I think it does drag out your recovery a little bit the longer the surgery takes, but honestly, most patients do fine. And prostatectomy patients live longer than everybody else because we handpick them at the beginning. So if you look at the survival curve for radical prostatectomy patients, they live forever because they're so healthy to start with. So it's not something that by itself is necessarily. Some patients clearly say, "I don't want surgery," and that's a perfectly good reason to opt for something else. But the risk, it's really your physician's job to try to define that risk.
Just a matter of curiosity, typically with radical prostatectomy, what is the length of time?
I think for most of it's around 2 to 3 hours.
Mm-hmm.
My chairman, Don Skinner, is really fast, and his take about 1 hour and 45 minutes. For me, it's about 2.5 to 3 hours. There are some surgeons in our group who take a little bit longer, so it's roughly that. And honestly, most experienced robotic prostatectomy surgeons are also doing it in about the same amount of time. And there's lots of breastfeeding going on about how long it takes you to do surgery because that's such a big deal. It's just something you can measure, really. But when they first start out, it often takes them a long time.
Is there a significant interval? Is there significant time during that surgery that's used by going back and forth to pathology?
No, very little in that particular surgery. Because of the thing I said about frozen sections, I don't usually do them at all, so
Thank you very much.
you're welcome.
Thank you for your presentation this evening. I have a question that relates to salvage prostatectomy.
Yes.
Is there a difference in your experience or the data that you've looked at between the outcomes with this robotic versus open?
You know, I've not looked at that specifically. So salvage prostatectomy is someone who's had radiation and failed and now has the cancer coming back in the prostate. And that is a very difficult problem. It's not, I mean, it's technically possible to do the surgery. It's not impossible by any means, and we do them, but our results in terms of the things that matter, continence, potency, complications like bladder neck contracture are all significantly worse than if you haven't had radiation. So it's, very commonly a patient comes to me having failed radiation, and, he chose radiation because he didn't like the complications from surgery. So now I'm telling him, no, instead of a 5% chance of incontinence, you have a 30 or 40% chance of incontinence, and he says, thanks, I'll see you later. So the City of Hope folks have done a lot of salvage prostatectomies and feel that they can do it safely. There's a lot of concern about rectal injuries because one of the things that happens after radiation is the prostate can get kind of fused to the rectum, so that can be difficult. But again, it's not the first case you'd want to do when you're taking up the robot, but I think it can be done.
What's the cure rate?
It really depends, just like on initial prostate surgery, it depends on your tumor characteristics. So if you started, and this is an example in my office right now, a fellow who had radiation for Gleason 8, had a PSA of 25 before his radiation, had hormones, and then got external beam. So he had a good response because his PSA was 0, but he was on hormone therapy. So we really didn't know how well he was responding. He stopped the hormones after a year, and now his PSA is back up to 5. That patient is not going to be cured with a salvage prostatectomy, most likely. But if you have somebody who's good risk to begin with, and that's, Gleason 6 or maybe 7, relatively small volume disease, before radiation, chances are you would have a pretty high cure rate after radiation. So it's very similar, the discussion is very similar. So because the complications are worse, if I think someone has a very poor chance of being cured, I will usually try to talk them out of salvage radical prostatectomy. If he's young and has a good chance of being cured, then possibly the risks are worth it. That's obviously for the patient to decide. But
The risk of complications is much higher though in the salvage.
much higher. And you know, you can do nerve sparing, but honestly, I've never had much luck with it in terms of actually having somebody functioning well after a combination of radiation and surgery.
I wonder how nerves can survive radiation.
It's a lot, yeah, it's a lot. It's asking a lot. But it is a very different, you know, that's an area that I think there's a lot of interest in so-called focal therapy, like cryosurgery. I think you guys had Doug Chin out here, who's a big cryosurgery. Is that what you talked about?
Yes.
Other types of focal therapy, HIFU, which is, you know, someday will come to this country, will be, I think, potentially very interesting in those patients because the complications from surgery are not insignificant.
Is it recommended that you see an oncologist instead of looking for some kind of therapy through surgery?
I think I think it's a good time to see lots of different doctors. The people that I should gonna get myself in trouble again. I'm not a big fan of redo radiation, and there are radiation therapists who like to do that. Someone has had external beam, they're failing, they'll do a seed implant or vice versa. And we've seen some real disasters from that kind of double radiation. It doesn't mean you can't do it. And Ken Takita, who's in this area, who I love, I know he's gotten away with it sometimes. It just makes me very nervous. As surgeons, we get asked to deal with the complications of radiation. So we see these disasters, even though they might be 1 in 1,000. But so I generally recommend against second radiation therapy. I think cryosurgery can be done. It does have more complications in a salvage setting, but it can be done. I think HIFU will have a role there. The guys at UC San Francisco are doing focal cryo, trying to just zap that part. So if I had recurrent prostate cancer after radiation, I would get lots of opinions.
Thank you.
Welcome.
Yeah, I'm going to risk a very basic question. What causes prostate cancer? Or another way to ask it is, what accelerates its presence? You have 2 cases up there, one 72-year-old, one 42-year-old.
We have no idea what causes it. There are lots and lots and lots of people trying to figure that out. And if I were going to guess where we'll end up 20 years from now, I think there are probably genetic factors, probably multifocal. There's not going to be a prostate cancer gene, but there probably are multiple genes, maybe genes related to androgens, testosterone, and how we metabolize. Just as an example, patients vary in their level of testosterone, but they also vary in how many testosterone receptors are on each cell and how active they are. So those kind of things may influence it. Your family history clearly influences it, which is probably genetic. There's very good data that diet is important, and it's unfortunately, once you get prostate cancer, there's not nearly as much data that changing your diet at 60 is going to make any difference. But a lot of people do, and you know, Michael Milken is the most famous example of somebody who's been alive way longer than anybody would have expected. And I don't know if it's because of his diet, but it's probably not hurting. But probably what we eat throughout our lives does matter. Fortunately, the same diet that's good for your prostate is good for your heart, which, you know, again, I'm big on putting things in perspective. You know, we know that a lot of patients die of prostate cancer, 40,000 a year. 400,000 Americans die of heart disease every year. So if you really want to take care of your health, you got to take care of your heart. So low-fat diet's good for that too. So, but honestly, we don't know. You know, there's a big trial looking at selenium and vitamin E that we're participating in that might give us some answers.
One more question, and that's watchful waiting.
Yeah.
If one is choosing that
Right.
approach, what's the trigger? When do you say?
That's
"Uh-oh"?
very controversial. It's, the difficulty here, and this will change someday when we have a way to see the prostate cancer through some sort of imaging technique. So right now, today, if you came in and had prostate cancer and I biopsied you and I said, okay, one core is positive, I can't put you in a machine and see that under any technique at all. MRI, whatever, ultrasound, whatever you want to do. We have no technique right now to see that cancer. Lots and lots of folks are working on that. It will happen someday that we'll be able to see it. Once we can see it, then I think watchful waiting will become more attractive, because the problem today is if I do a biopsy and I find one core of Gleason 6, everybody thinks that's the patient, PSA is low, that's the patient who probably could go on watchful waiting safely. But if I take his prostate out the next day, I know that in 60-70% of the time I'm going to find multifocal cancer, and occasionally I'll find Gleason 8 prostate cancer on the other side that I completely missed, even though I biopsied the heck out of his prostate. So the lack of imaging is a real problem. But I always talk to patients about watchful waiting, and those patients with that low-risk disease, my 72-year-old guy that I presented, we know that it's probably 5, 10, 15 years before his life is threatened by the cancer. Whether we can intervene in between and get the same result, in other words, could we watch him for a year or 5 years and then do a radical prostatectomy and still cure him? We don't know that. So there's another big trial that is opening, comparing watchful wait. It's a randomized trial. We'll see if they can do it. The Canadians are starting it. There'll be some American sites as well, comparing radical prostate, any surgery. It can be surgery, radiation, or watchful waiting. And they've set up what I think are kind of arbitrary triggers. So they follow your PSA and your exam. If your PSA goes up by more than a couple points, they recommend repeat biopsy. If your exam changes, you repeat the biopsy. And if the biopsy gets worse, you recommend intervention. But that's kind of unproven. I mean, we don't know if that's really the right trigger. So if I have patients on watchful waiting, if I have a patient that I really think should get treated, a 60-year-old healthy guy comes in with kind of a lot of cancer in his prostate, and I really think he should get treated, but he says, I don't want treatment, I'll follow that patient, but I really encourage him to have serial biopsies at least once a year, because I'm so worried that his cancer is going to get worse. If somebody comes into me, with bad lungs, bad heart, 2 strokes, and I think that I'm recommending watchful waiting because unfortunately I don't think his survival is very good, I may not re-biopsy him, because why would I do that? So I just follow him with his exam and his PSA.
Before we close, I'd like to thank you again for your outstanding
You're welcome.
presentation, and as a